how do you feel about all the explosion of XRT in private practices, in the use of XRT without having seen a Mohs surgeon, without having seen a dermatologist? Am I wrong? Is there anything redeemable about this practice or is it completely off kilter, as I think?
I'll take a stab at that, since no one's really terribly eager to. I think it is a very controversial issue, and I'm sure some of the members of the audience know some of the things that have already happened. The American Academy of Dermatology developed a position statement on this about 5 years ago, and just recently revised that position statement. But that initial position statement was in response to what was perceived as the primacy of using radiation as a tool for practice development rather than something that was in the best interest of the patients. But I would agree with you that there seems to be a business model where this is what people go to first, and there are reasons for that. Often these procedures are delegated, and they often have multiple fractions, and then there's been controversy about how many fractions are necessary, and obviously the number of fractions is associated with the degree of reimbursement. And then there are multiple technologies, including the superficial radiation therapy that dermatologists have worked on for decades, but also so-called electronic brachytherapy, which has been compensated at much higher levels, even though objectively it's almost indistinguishable.
And Laurin, perhaps I'm incorrect, but how often do you see that it's appropriate to biopsy 10 lesions at a time for somebody coming in who has never seen a dermatologist? Is that, again, I think that it's unfortunate. My editorial is it's very difficult and very uncomfortable for us to call out colleagues, but I think that, this has to come out into the open in order for us to address it as a specialty. Again, maybe I'm wrong. Maybe there are people who routinely biopsy 10 lesions, and certainly at a medical institution like WashU, you may get that. But is that even common for you to have 10 biopsies at one time?
No, I think the article was trying to highlight that a physician extender may be uncertain about more lesions and may be performing more biopsies due to some of that uncertainty. There may certainly be someone who presents with more than 10 skin cancers, but for a lot of reasons, I try to prioritize and biopsy things that need to be treated more urgently. If someone has 10 biopsies, it's difficult to determine which biopsy site was the cancer. It's much easier if you just have 4, biopsy those, treat those, and then kind of see the patient back regularly and determine what the next step should be.
I think we can make mistakes on both ends. I think we can see a case of a melanoma and be very kind of aggressive with that one lesion. But we can't forget that there are many people who present, 5% of them with multiple melanomas, and there may be 2 or 3 melanomas that present at one time. On the other hand, if we recall, my number needed to treat was 2 for melanomas greater than 6 millimeters. The average dermatologist would only be taking about 10 to 15 melanoma-oriented biopsies per year. Now when we come to the issue of basal cell and squamous cell carcinomas, which are much more abundant, the likelihood of patients to have those lesions to achieve a kind of danger level, with numerous large squamous cells greater than 2 centimeters or of an aggressive subtype, the likelihood of us presented with those patients is very low. The most common patient population which I might see that is a patient who has organ transplant, immunosuppression. And that type of patient, I might get to 4 or 5 biopsies, but I can not remember a time when we actually laid out 10 biopsies per patient.